Okay, we're live.
Okay, welcome everybody. I'm going to call the meeting to order. This is the Connector Board meeting for May. And Kathy, I think you need to take a roll call.
I do. Okay, good morning, everyone. Okay, Rebecca,
Present.
Michael,
Present.
Elaine,
Here.
Eric.
Present.
Okay, is Martha? I'll come back. Keisha,
Good morning, present.
morning. Dimitri, seeing him. Okay, Karen,
Morning, present.
morning. Nancy,
Good morning, Kathy. I'm here.
morning, Nancy. Good. Matt,
Good morning, I'm here.
okay. Rena. Okay. All set, thank you.
Okay, so thank you and welcome everybody. So the first item on the agenda is approval of the minutes for March 9th, 2023 meeting. So I'm going to entertain a motion to approve those minutes.
So moved.
I think we need a second, is that right?
Second.
Okay. All right, Kathy, can we take the vote?
Yes. Rebecca,
Aye.
Michael,
Aye. Yes.
Elaine,
Aye.
Eric.
Aye.
I'm gonna do Martha again, just in case I missed her.
Here, sorry.
Okay.
Yes,
Okay, Keisha,
Yes.
Dimitri, if he's joined us. Okay, Karen,
Aye.
Nancy,
Yes.
Matt,
Yes.
and Rena if she's here.
I'm here.
Thank you, everyone.
That was a yes from Rena, I think.
Yes, it was.
Okay, so the next item on the agenda item is the executive director's report. So I'm turning it over to you, Audrey.
thank you so much, Michael. And thank you for chairing today. Good morning, members of the board, and welcome to today's meeting. We have a full agenda for you, and we'll kick off with what remains our topmost priority this year, which is the Connector's work to serve as a coverage destination for people who might lose MassHealth as a part of the 12-month Medicaid redetermination process that began last month. For this presentation, we're happy to be joined by MassHealth to provide an early update on the Medicaid redetermination process before we get into the ongoing work of the Connector to be as supportive as possible to residents transitioning to a new source of coverage. It is certainly early days, but so far, operational processes have worked as expected, and we are seeing optimistic early signs of enrollment uptake as some people start to move through the redetermination process. We do expect that volume will increase in the next few months as completed redeterminations by MassHealth begin to result in terminations, and we continue to expect that we will be able to manage that volume as it intensifies. During today's meeting, we will ask for your approval on some targeted regulatory amendments that will shore up protections for $0 cost sharing for preventive services for Massachusetts residents. Currently, the minimum creditable coverage standards include access to preventive services and require that they not be subject to a deductible. But a recent federal court decision has prompted us to propose strengthening these rules to mirror the $0 cost sharing requirements provided for by the Affordable Care Act. With this proposed amendment, Massachusetts taxpayers seeking to comply with the state individual mandate and meet MCC will need coverage that includes $0 cost sharing for preventive services, preserving ongoing access to these vital services that Massachusetts residents have had in their coverage for the last decade. Also today, we will be providing a high-level overview of recent policy updates that shape our work and influence the health coverage landscape in which the Health Connector operates. Before we get into today's agenda, I would like to take a minute to provide you insight into two areas of work that offer valuable new insight to us to help strengthen the Health Connector's work delivering on its mission. Last month, the Blue Cross Blue Shield of Massachusetts Foundation published its Closing the Coverage Gaps report. This report brought new data and analysis forward on the uninsured of Massachusetts and some of the reasons why many residents continue to lack coverage. The report, based on pre-pandemic data, finds that of the uninsured population, 42% are between 19 and 34 years old, 40% are born outside of the United States, and 30% are non-citizens. And critically, nearly 70% would qualify for MassHealth or a connector care plan. A stark reminder that so many of the people who need coverage would qualify for something free or very low cost. The report identifies cost, language access, and other administrative process challenges lead people to not seeking out coverage and includes an array of policy approaches for consideration to help address these barriers. The report's findings will help inform and augment our own internal analyses and data to help shape the connector's efforts in the coming year and beyond to cover the uninsured. A bit closer to home, I also wanted to provide the board an update on our administrative burdens audit, which we sometimes call a sludge audit, that we discussed with you at our board meeting last November, when we voted to bring MassHealth Strategies on board to help us conduct an audit on ourselves to identify points of friction and burden in the process of getting and staying covered, especially those that further inequities. We have been working with Manat over the last several months to do a hard target search of our entire online enrollment process, all the way from login to payment, in an effort to identify areas where people run into problems, spin in circles, or abandon the process. Manat spent time with individual applicants and members, watching them in real time use the system to see where questions or barriers occurred. Many applicants experienced confusion, frustration, and essentially dead ends that made it hard for them to finish their enrollment or account updates. We've long known that the online HIX experience can be confusing and difficult for members. I can tell you that it was painful at times to hear and watch how frustrated applicants and members can feel at various points of the process, and to see that for many people, it results in them not being able to get into or keep the coverage they want and need. But we know that we need to sit with that and own that discomfort and let it further deepen our commitment to rolling up our sleeves and addressing these burdens. The consequences of not doing so are residents not getting the coverage and benefits they need, want, and are entitled to and deserve. The review by Manat identified dozens of areas in policy, technology, and system display where members noted issues and changes would make a difference in their experience. Now, with the initial review period of that audit completed, we're moving into a new and final phase of the project with Manat, taking steps to prioritize areas for updates and fixes. The Commonwealth has so much to be proud of in terms of how hard we work to make coverage affordable and robust and protective of consumers, and the work we do to educate and outreach to the public about getting coverage. So it is vital to make sure the actual process of obtaining it is easy and smooth and respects the time and integrity of the members of the public we serve without sending them in circles, drowning them in paperwork, or confusing them. We see removal of administrative burdens as a key next phase for the Health Connector in delivering on the promise of health reform and a critical next frontier in pursuit of health equity. We will plan to share with the board a comprehensive update on the findings of this audit as our second phase of work with Manat comes to a close, and we will look forward to engaging with you and apprising you of our progress to put in the rearview mirror the kinds of taxing administrative burdens that keep people from coverage they qualify for. So with that, I will close by thanking the incredible team at the Health Connector for the full tilt work they do around the clock, week after week, month after month, to push us all to be all over redeterminations and supporting the Commonwealth through this major coverage transition period successfully, and doing all of this while striving with an eye toward the longer term to push ourselves to be the most effective and forward-leaning marketplace we can be. So with that, I will hand it back to you, Michael.
Audrey, thank you. My internet is a little wonky, so if I go, I apologize. I think Nancy has a question before we move on.
Yeah, thanks, Michael. Audrey, thank you very much for that update. I'm glad you mentioned the Blue Cross Blue Shield Foundation report, which I think was such interesting reading, and I think gives us lots of important information and insights about how we can move the needle here. I wonder if you could send it around to all of the board, just so everybody has a copy, please.
Sure, yes, we can definitely follow on with that.
Great.
Thank you, Nancy.
Thank you.
Great idea, Nancy. Other questions for Audrey? And Nancy, your hand's still up. But okay, I think the next item on the agenda, in the spirit of the real focus of everything's going on, is the update on the MassHealth redetermination and enrollment transition. And that's going to be presented by Marissa, Patricia, Jason, and Elizabeth, but I think we're starting with Marissa. So Marissa, I am turning it over to you.
Great, thank you. Good morning, everyone. So, We're pleased to bring updates today related to the MassHealth redetermination process that started since we last met, and we're lucky to have Elizabeth LaMontagne here from MassHealth joining us to share information about the process from the MassHealth perspective, as well as updates on enrollment and Health Connector plans, operational performance, and outreach initiatives. So just as a brief refresher, federal protections of Medicaid benefits that were part of a 2020 COVID relief bill ended on March 31st, beginning a year-long process whereby MassHealth will gather fresh information about all its members to see which of them still qualify and which may move out of the program. Since redeterminations began on April 1st, we've seen members begin to leave MassHealth coverage and qualify for and enroll in Health Connector plans, most without gaps in coverage, which is excellent. Things are running smoothly so far, but we know that activity will intensify in the months to come, and we're continuing to prepare to meet individuals where they are in this process. And from there, I can turn it over to Elizabeth.
Thanks, Marissa. And thank you all for having me today. I am currently the Chief of Staff at MassHealth. And to start off, I'd love to just share a little bit about how we at MassHealth are thinking about this redeterminations process. In some ways, redeterminations is an annual process that we have done for many years, and that really rely on existing proven processes. But there's two reasons that this year is really different. The first, as Marissa mentioned, there have been federal continuous coverage requirements in effect for almost 3 years now. And those continuous coverage requirements have resulted in our caseload growing significantly, from about 1.8 million members to 2.3 million members. So we have more members going through this process than we have in past years. Second, because of these continuous coverage requirements, members may not understand the implications of their renewals, because we've been conducting renewals, sending out renewal letters, but if members have not responded or if their eligibility has changed, historically, because of these continuous coverage requirements, they have not experienced any loss of coverage. So we recognize that we have work to do to make sure that members understand that if they don't respond to their renewal this year, that may result in a loss or downgrade of coverage. So to prepare for this increased volume and making sure we're clearly communicating with members, MassHealth has really been working over the past years to make sure that we have the operational capacity needed to support our increased volume, that our system is prepared for the volume and for members coming in, that we're really able to do that proactive outreach to members, to stakeholders, to partners, to make sure that the process is clear and members understand the actions they need to take. And also making sure we're thinking through specific populations and that they have the supports and access they need to the MassHealth system. You can see our goals to the right of the page for this redeterminations process. And what I'll just highlight is this is really focused and centered on ensuring members receive the best benefit that they're eligible for following this process, whether that's staying on MassHealth in their current benefit, transitioning to the Health Connector, or finding access to employer-sponsored insurance. We're really focused on making sure that members know what they need to do to receive that best benefit they're eligible for. And a huge, huge piece of this going successfully is really making sure we're outreaching and communicating with members effectively. So there are three of the most important messages that we're working to get out to our members, to our partners, to the community. And the first is calling to update your contact information. We recognize members likely have moved, possibly since they last went through a renewal successfully. And it's most important that they're telling us where they live now, what their email and phone is, so we can outreach them effectively. So when it's time for their renewal process, they will receive that information and know they need to respond. The second message is making sure they're checking their mail. When they're selected for renewal, they'll receive a large blue envelope in the mail containing that renewal form that they need to complete and submit to MassHealth. And the third message, of course, is responding to MassHealth, making sure they're getting their information to us prior to the deadline so they can receive the best health benefit that they're eligible for. We have a wide array of outreach efforts that we have been conducting and will continue to conduct throughout the redeterminations process. but 3 items that I wanted to highlight. The first is that while we are mailing those blue envelopes, we want to make sure that's not the only path that we're outreaching members and telling them that they've been selected for renewal. So members will receive a robocall, a text, and an email alerting them when they've been selected for renewal during this upcoming 12-month process. We've also developed additional supports, in some cases specific messaging or flyers. We've been holding webinars, supporting specific populations, thinking about how we can make this process clear and straightforward for older adults, making sure it's accessible for individuals with disabilities, making sure we are connecting with individuals experiencing homelessness, and supporting non-citizens as well as they go through this process. And last but not least, we also partnered with Healthcare for All to launch the Your Family, Your Health campaign. And I'll talk a little bit more about this later in the presentation, but this campaign is focused on the top 15 towns and cities in Massachusetts, where there are the most MassHealth members at risk of losing their coverage. And this campaign will include door-to-door canvassing, community-based organization grants to hold events, and media buys, really spreading these 3 key messages and making sure that individuals know what actions they need to take to receive the best benefit they qualify for. So we did start this effort, right? It's mid-May, we're about a month and a half in, but this is really an effort that's a marathon, it's not a sprint. So I have some initial information to share from the first month, but this will really be an ongoing dialogue and really evolve as we go through this process and learn more. So in the first month, we began the renewal process for about 70,000 households. Most of these households will be processed in May because individuals have 45 days to respond to that renewal. We'll have more information about the changes to the MassHealth caseload in April when our public dashboard is released, which is expected to launch this month. During the first month, our systems and our contact center are operating as expected. When we look at metrics like average speed to answer, abandonment rate, we're where we're expecting to be, and our processing of mailed and faxed applications is also on track. There's no sort of backlog that's building up. And importantly, we're also continuing to do that really extensive outreach, working with partners, trusted sources in the community to make sure we're getting that message out. In April, we held over 30 stakeholder presentations for different groups across the state, and we've done over 110 of those since January. And those presentations are really focused on, depending on the audience, making sure we're sharing what resources exist to help members, where we have language access supports, where members with disabilities can find supports they need, making sure individuals understand the process from start to finish, and that we're able to share resources like certified application counselors, the MassHealth enrollment centers, the contact center, to help individuals know that there are supports that exist to help them complete this process. And last, again, the partnership with Healthcare for All. In April, this really has kicked off. So they've engaged 42 community-based organizations to conduct that outreach activities in advance. These are trusted organizations in the community that will be really effective at engaging with our members. They've also already knocked on nearly 146,000 doors in those top 15 communities. And they've spoken with about 26,000 people, telling them about this process, where they can get help, and what to do when they receive their blue envelope. And of course, we've also launched a multicultural, multilingual ad campaign in more than 60 media outlets. There's obviously infinite information about redeterminations that I could share, but I wanted to leave you all with where you can learn more and where you can find some of those resources I mentioned. So on mass.gov/MassHealthRenew, that's really the hub of information for us for MassHealth. On this page, you can find the link to the member-facing website, masshealthrenew.org, which HICPA has the resources where you can find an appointment at a MassHealth enrollment center, where you can find a certified application counselor in your community. You'll also on our website find the outreach toolkit, which has a lot of those flyers, social media posts in the top 9 languages of our members, and the MassHealth Renewal Help Guide, which is a really detailed resource, which can be wonderful for frontline staff who maybe interact with a lot of MassHealth members, but aren't a certified application counselor themselves, helping them understand where to direct them for more support, with also examples of frequently asked questions that we expect to hear in the coming months. And last, there are a number of recorded webinars focused on specific populations and other resources as well. So mass.gov/MassHealthRenew is a great site to learn more about this process. Thank you all so much for having me. And Marissa, I'll hand it back to you.
Great, thanks, Elizabeth. Are there any questions on this part before I move forward? Nancy, I see your hand.
I don't know if Michael disabled my hand because I didn't. use
I didn't disable your hand, but I was going to note that was the real old school hand. I can't see, just to be clear on my internet, I can't see everybody's hand. So if you actually do the electronic hand, you jump up to the top of the screen. I did not, I even if I wanted to, Nancy, I have no power over the
Oh, I
hand.
know. I'm just teasing. As someone who has taught online also, I'm impressed that you can talk and see a hand at the same time. Elizabeth, thank you very much for that update. And I have to say how nice it is to have someone from MassHealth with us. And I hope as we continue over the months, maybe updates from MassHealth can become a regular part of our board meetings. As you know, much better than anyone else, there's such a close connection between our programs. So thanks for taking the time to come and talk to us. I had a question about what, if anything, we're doing about the fact that the plans offered by the Connector and Connector Care are different than the ACOs that MassHealth offers, and what you all, and I guess we have learned about that, and any special education or outreach we need to do to explain to people that they might actually have to switch to something that's named something different. Or could you just tell us a little bit about that?
Yeah, that's a great question. I might actually hand that off to Marissa, because I believe the Connector does most of the outreach to members once they've been determined ineligible for MassHealth and eligible for a Connector plan.
Yeah, and I think it works the other way too. So if happy to have anybody answer that. This has kind of long intrigued me, and maybe it's just working really well and I should stop asking the question, but.
Sure. So we have definitely been in communication with the carriers about this, and they're in the best position to be able to say to their members, we know on the MassHealth side of our shop, this is where you are, here's what we look like, how to find us on the QHP side. And so, they're able to do that outreach in a very direct and specific way and help members crosswalk their providers. We did ask at a high level last summer, I believe, to say, can you please compare your networks in your MCO and ACO products and your QHP products, and let us know, are your MassHealth members using overlapping providers? How many people may be in a position where the doctor that they're seeing under their MassHealth coverage isn't available to them anymore. And so there was a substantial amount of overlap in that comparison. And so it does seem like most people will be able to kind of continue with their provider along with the same, general issuer umbrella when they shift over. But certainly that is, case by case, and we're working with the carriers and asking them for more information about what do you do when somebody calls, where do you point them if they need help finding a provider that's accepting new patients, for instance. Have you examined that capacity and made sure that it's robust enough for people to be able to get care they need once they transition? So certainly things that we're in dialogue with the carriers about, and I think they're also tuned into the fact that they're best positioned to be able to help people do that crosswalk between their MassHealth and QHP products.
Yeah, thanks, Marissa. I know that our most important priority and imperative is just being sure that people keep coverage. I do think this is worth trying to get a better understanding of as we go through this process. And I just raise it as a concern and leave it to all of you to decide where it falls on your very long to-do list. But I do think the fact that MassHealth has moved in a different direction over the last few years in terms of plan offerings from us, I think learning that it actually hasn't had an effect would be a good outcome. And if it does have an effect, I think we need to understand it more.
Absolutely. We'll continue to monitor and loop you in on any developments there. If no other questions, I can move into the Health Connector component of our update. So far, the population that we've seen moving from MassHealth to connector eligibility is an active and engaged one. The majority of these individuals have proactively come to the system and made updates to their application in a way that fulfilled their renewal requirements. They didn't wait for that blue envelope to come to them. And as a result, we're seeing what we understand to be a relatively high conversion rate, so to speak, in terms of enrollments among those who newly qualify. It's about 27% here. While enrollments are exceeding forecast at this point, I'll note that, we are expecting to potentially see different dynamics emerge as more individuals are selected for renewal and as individuals start to have their renewal windows expired for non-response, as Elizabeth noted later this month. So, many of these proactive individuals also will have received a request for eligibility verifications that'll be due later this summer, and they may experience eligibility changes if they don't respond to those. So we're monitoring all of that closely. We're ready with our messaging and our notifications, but we just wanted you to be aware that this picture will grow more complex over the next several months as people continue to react to things that they're getting in the mail, changes in their coverage, and that we're preparing for all of that. We do have a number of strategies in place to support people as they go through this very complex process. So we've extended all our special enrollment periods granted after April 1st to November 23rd, which is the last day to enroll for 2023 coverage. We also have some policies that have been in place for a while that will be useful during this transition period, including MassHealth termination rules that extend coverage end dates for people who lose MassHealth and transition to a subsidized connector eligibility. And we have flexibility in our retroactive coverage tools that allow us to be responsive when people call and say, I missed the boat on sending something. Here are the changes that I've experienced. I would like to go and fix that mistake or update my information now. So we have flexibility to help solve those problems with those tools. And in terms of reducing administrative barriers, we have our automatic enrollment process that we started last year, has seen very robust uptake. And that includes 130 individuals who were enrolled for May coverage after losing MassHealth. And additionally, we've had an increase in the range of incomes that we can automatically consider verified by the data that we're getting back from IRS or DOR. And that helps reduce paperwork burdens on people as well. So any questions on this section before I turn over to Trish? Right. Trish, take it away.
Thank you, and good morning, everyone. So just a quick update on contact center performance. Our volume has only risen slightly, so our forecasted and actual offered numbers are very close. We are what we would consider to be overstaffed right now with our excess capacity making outbound calls to folks that have come over to the connector. So our service levels at this point continue to be in the mid to high 90s. I think yesterday's service level was closer to 100. So we're doing very well on the phones at this point. On the next slide, we are adding additional language capacity to our IVR, which will, the IVR is the automated menu on the phone, the 800 number. We will be mimicking the updates that were made at MassHealth a couple of years ago. And when folks call in, they'll be able to choose their language. They will hear a welcome message in their language. They will either be routed to an agent that speaks their language, or if they're on hold, will receive hold messages in their language while the customer service rep is notified to get the appropriate interpreter on the line. So we are working with Accenture right now. We're anticipating that will be available relatively soon. And this will help minimize us having a caller that doesn't speak English trying to get through to a customer service rep who only speaks English. On the next slide, where we continue to work with Accenture on our staffing levels, We do have forecasted numbers, I believe at this point now through August. And we continue to work with them on those numbers as we take a look at increasing number of calls, the number of applications that are being sent out to MassHealth recipients. What we're also proposing is an additional buffer of customer service reps throughout the upcoming 12-month period. And that will help to make sure that we have available capacity in case the volume goes up. We also have a second vendor who's available. They'll be starting in mid-June. We'll have a second wave of FTEs in mid-July. They will help process paper in the event that we pull Accenture paper processing staff over to help if there's a spike in incoming calls. If there is no need to have them process paper, we will continue to have them make outbound calls to folks who are either connector eligible and need assistance in choosing a plan and making a payment, or to be proactive to call individuals to let them know that their blue envelope will be coming in the upcoming weeks and the importance of getting that information back to us. And then finally, we are in the process of interviewing for our mobile outreach teams. We will have 2 outreach coordinators in each of the 4 areas of the state. There'll be a supervisor who's helping to coordinate. They will go to local areas, pharmacies, libraries, food pantries. We will also spend some time at shelters, and we will help staff the events that both the Connector and MassHealth will be having across the state. So far, we've gotten very good response to those positions. So we're in the process of interviewing and hiring, hope to have folks trained and ready to hit the ground on July 1st. Any questions? Nancy?
Nancy.
Yeah, thank you very much, Trish. And I think, just want to reiterate what others have said, thanking all of you, including colleagues at MassHealth and all of our community partners for all the work you've done, and I know will continue to do. I think Elizabeth rightly said during her comments that this is a marathon and not a sprint. But I'm wondering, like, when in the coming months do you think we will start getting a best sense of like how this is going? So July 1st is obviously an important date, but like how are you and others thinking about that?
So on the contact center side, or from that perspective, we've looked at things like, when blue envelopes are being mailed out, when that 45-day hits, when someone potentially gets a termination notice and then another notice saying it'll be a couple weeks before they're actually terminated. So all of that information was used to put together our forecast. Our original expectation was end of May into June is when we thought we would start to see volume go up, and then continue to go up throughout June and July, because as it's almost like rolling termination. So you have the first group that's out there that calls, and then there's a certain percentage of folks who don't call and potentially go to a provider and then have to call to say, hey, I just found out I didn't have insurance. So there's a percentage that will call, and then you have the next wave on top of that, and the next wave on top of that. So we've taken all of that into account. Accenture spent many, many hours, and we had a lot of different meetings with them to go over what we thought that volume would be. So I would say end of May into June is when it will start to go up. And then obviously we have mixed households that go out in August, and we would start to hear from those folks towards the end of September, October. And then obviously that brings us into open enrollment. So I would think once we start to escalate in volume, it will continue to grow and be a steadier, higher volume moving into 2024.
Okay, that's helpful. Thank you.
Yeah.
Okay. I think we can.
Hi, good morning, everyone. I'm going to run through where we're at on communications and outreach. I think probably reaching out directly to newly eligible people is our top priority during the redetermination process. It's just the best way for us to provide visibility, information, along with connections to help and deadline reminders to people as they go through the process. through all forms of contact, text, email, mail, and robocalls. People should receive something pretty much weekly from us for a handful of months, with multiple contacts in the days leading up to deadlines through different platforms. We did start our calendar of communications last month, and things went relatively smoothly. We're confident that we'll be able to continue to meet our planned activities as volume increases over the next handful of months. Last month, I'll note we did launch our texting functionality as a pilot project. The redetermination population was part of a larger group receiving texts. Mail and email was sent on a subscriber level, not a member level. So that's why the numbers may appear a little bit smaller compared to the overall member population. Email is sent to newly eligibles from the week before. So for example, yesterday we sent an email to people who were newly eligible last week. We also emailed deadline reminders to the entire eligible group as we get closer to the 23rd. Robocalls will begin this month. They will be encouraging enrollment and assistance, and also noting deadlines. And I guess the last thing I would note here, just on the email, our open rate over 40% for both the weekly and the deadline emails is really good. You know, typically over like mid-30s percentage-wise is good. So far so good on member communications, and like I said, we will continue to run through our calendar going forward. On the next slide, Marissa, thank you. For public outreach, there is a lot going on in this area as we sort of transition out of our planning and training phases and get into execution. We'll be participating in visibility and informational activities on the community level throughout this process. It starts this weekend. We have 9 events already slated from this weekend through mid-July. The first of which is the world's largest pancake breakfast in Springfield this Saturday. So if you need breakfast plans for this weekend, we will be in Springfield participating in that. Virtually, we continue to hold monthly webinars. These are things that we've done over the last few years on a regular basis. Obviously now we're turning our focus to redetermination information for people who are participating. We did see an upswing in participation last month already. As we move into this, we suspect these will be more and more popular as time goes on, and we do record these so people can watch them later. Later on this summer, we'll be doing webinars in Spanish and Portuguese, and those will also be recorded. Trainings for navigators and certified application counselors is complete. But we do continue to have regular and frequent meetings with those folks to ensure we have insight to any trends or issues that they're seeing out in the field, and also just sort of making sure they're all on the same page in terms of having the appropriate information and processes available. We did publish our social media toolkit at the end of March. It was distributed to stakeholders around the state. This, obviously makes it easier for entities to turn around and add to our visibility through messaging on their platforms. And we are continuing to work to create visibility to employers in the business community and directly to businesses. We know that many people who are moving out of MassHealth will be eligible for employer-sponsored coverage. We want to make sure employers are aware and ready to support employees in enrolling in the company plans as practical there. Thanks, Marissa. So enrollment events are going to be a big part of what we do for direct new member support. We anticipate having well-promoted busy events over the next year. The first one will be next month on June 11th at Fenway Park. That one will probably feel a little bit more like a kickoff and visibility, although enrollments will be done. We are the lead sponsors of El Mundo's annual health fair that day. Typically, this is a very, very well-attended event. We expect the same this year. We'll have at least 10 navigators on hand, ready to support people who need help, which will be consistent throughout these events. We'll make sure we have plenty of navigator and CAC support if necessary. This graphic here shows the potential for what we anticipate will be significant signage and visibility at that event. The arrows are something that we'll be using throughout our marketing pieces during the redetermination period. So we're kind of bringing all of the, visual images together here for the Fenway event. Carriers usually have a big presence at this El Mundo event, and they have been invited. They have our schedule of other events, and some have already provided us a list of events they plan on attending, so they can stop by, have information, maybe some swag, make sure people are getting more information about available plans as they enroll. After the Fenway event, we'll be turning to self-created events that will be, really heavily enrollment focused. As I said, we're working with our navigators to ensure we have adequate staffing at all of these events. And also to make sure they have the infrastructure they need to be successful, right? They need to have good, fast Wi-Fi. They need a scanner. They need access to the cistern line, maybe, to make sure they can do ID proofing as necessary. So we're going to make sure, these are really going to be almost sort of like mobile or pop-up enrollment centers at these events. And hopefully they can help people get to where they need to be. These events will be heavily promoted in advance, a couple weeks in advance, through local media, and we'll also do direct mail to newly eligible residents who are on our list. And then on paid media, it's starting to ramp up. We've been doing some NBA and NHL playoff partnerships that are centered on awareness and availability. Hopefully those continue after tonight. That's kind of up to the Celtics, however. That will rapidly change in the next few weeks as we add platforms and sharpen the messaging to more directly focus on the redetermined population. Along with what we would consider a traditional open enrollment media buy in ethnic media outlets in Spanish, Portuguese, Haitian Creole, Chinese, Khmer, and others. We'll be working on broader outlets like television and out of home, like billboards and public transportation. And yes, Nancy, I see your soccer ball. We are working on partnerships with Telemundo and Fox for the Women's World Cup. They will be very similar in structure to last year's in terms of the number of games and the additional activities that we have going on with those stations during the tournament. I would say one unique item of note here with 25 is the zip trips. Those are a very popular Friday summertime staple for the station. The morning show goes on location to different communities around the eastern part of the state. People show up. These are sort of, good community events, and people, go somewhere at 5, 6, 7 in the morning to watch the show. We'll have the opportunity to be on site every Friday. It's also the 20th anniversary of the zip trips, so we expect that they will be pretty heavily promoted. So those usually start, I think, right around the 4th of July and run through the summer. So that's where we're at, excuse me, on outreach and communications. Anyone has any questions, happy to answer.
Thank you, Jason. So in terms of moving forward, helping individuals stay covered during this time of transition is, as Audrey noted, our top priority this year. And it really has been and will continue to be a team effort internally, as well as with our external partners and of course you all. And we're very grateful for all of that collaboration. We'll be back with updates at our next board meeting, but welcome any questions that you might have now.
Okay. Nancy?
Maybe I can just ask.
I was just waiting for you to have a real or virtual hand.
Okay. So maybe I can just reiterate just a question I had asked another time, just about if we discover that our partners on the ground need additional resources to do the work that needs to get done as all of this continues over the next year, what plans we have in place to make that assessment and provide the community partners and navigators with the resources that they're going to need to be effective at doing what they're a very substantial part of this work too.
Yeah, so I think we would in the short term, make more resources available. If there are part-time people who need more hours or if they need overtime. We are also going to have, let's call them regional support networks. If there's, one navigator in particular that's in the soup, someone nearby can send an extra set of hands over. We'll also create some virtual opportunities where, if a navigator has a line out the door, they can set up an extra computer or two and people can sit down and talk to another navigator somewhere else. So we're going to have all these sort of contingency network plans in place where if there's like an immediate need, right? Like if somebody wakes up on the 22nd and they're overwhelmed with people, they can get some immediate help. And we'll also maybe leverage the community specialists in a real pinch if we need to make sure everyone's covered.
Yeah, I just think that's great to hear that you all are already thinking about that. I think, having those contingency plans ready to go so, we can immediately intervene and bring the support on the ground to the folks who are going to need it. It's going to be critical.
Yeah, I agree. And this is just really spectacular set of things you're doing. There's so many balls in the air and you seem to be keeping them all moving in the right direction. I'm impressed with the whole team effort. Marissa, I think that wraps things up.
Yeah.
I'm getting a message that my internet's unstable. We'll see how that goes. But in any case, I think we're now going to move on to the next topic. But before we, if that's okay, Marissa, I want to stop. Some people might have wondered why I'm here instead of Secretary Walsh. So again, I might turn on the vice chair. That's sort of why I'm here. But I do want to give the opportunity to welcome Karen Sang, who's here. She's representing for the EHS leadership team. She's representing Secretary Walsh. So Karen, welcome. You're actually not on my screen now. There you go. Do you want to take a second and introduce yourself? We'll all collectively welcome you to the meeting.
Thanks so much, Dr. Chernow. It's great to see old friends and new. And I'm a senior advisor in the Office of Health and Human Services and working directly with our Undersecretary, Kiami Mahania, and Policy Director, Amy Bianco. I think many of you will have met Amy over the past few years. And the portfolio that we're supporting the Secretary on encompasses, of course, the tremendous work of the Connector and the corresponding work of MassHealth, and some broader work around affordability, access, and what we're calling healthcare system performance and sustainability. So very much appreciate the expert, really the tremendous weight that this board holds and the perspectives that you bring. Looking forward to continuing to support this work. Thank you, Michael.
So wonderful to have you back in Massachusetts, Karen.
Thank you so much, Nancy.
So that is a collective welcome. Welcome. So our next topic is one of particular interest to me, and I think it's really important for the board. Of course, we strive to get everybody covered, and we spend a lot of our time doing the nitty-gritty of what covered means. There's a lot of stuff going on nationally about sort of coverage levels and what it means to have minimally credible coverage to count. I won't try and upstage next presentation, but we're going to now we're going to go into a discussion about minimally credible coverage and how we're addressing the changes that are going on. We will have a vote as part of this, but I think right now we're going to listen to Kayla and Andrew discuss this sort of issue. And I think, Kayla, you are going to start it. So I'm turning it over to you.
Yes, thank you. Good morning, everyone. Okay, so today Andrew Egan and I will be reviewing proposed draft minimum creditable coverage amendments. Staff seek a board vote today on an amendment to MCC regulations to specify that no cost high-value preventive services must be included in coverage that residents have to enroll in to avoid paying a tax penalty. This amendment preserves coverage standards that are current practice in the Massachusetts market today, despite a recent federal court ruling from the Northern District of Texas. In this presentation, we will review a refresher on minimum creditable coverage, the legal challenge against the ACA's preventive services mandate, recommended regulation amendments, and finally, we will request a board vote. Okay, so I'll begin here by providing a high-level overview of the individual mandate and minimum creditable coverage, or MCC. As part of Chapter 58 reforms, Massachusetts law requires adult residents to have health insurance that meets the state's minimum creditable coverage standards or potentially face an individual mandate penalty. State law defines MCC at a high level and authorizes the Health Connector Board to further determine the minimum standards of plans that individual residents are required to have. This is done through MCC regulations. The Health Connector's MCC regulations govern what constitutes minimum creditable coverage for nearly 5 million state residents. So what we're discussing here today is broader than just Health Connector coverage. MCC outlines the type of coverage a person needs to have to avoid facing a tax penalty under the state's individual mandate, establishing a floor of benefits required to check the box as having been covered on their state tax forms. Today, staff are proposing draft amendments to the regulations at 956 CMR 5.00 to ensure a recent federal court ruling does not weaken access to the existing robust coverage of preventive services in Massachusetts, or change residents' ability to afford and access these services. While MCC does not apply to the health plans directly, plans often choose to meet MCC standards so that their members don't face tax penalties and so that their coverage remains attractive to Massachusetts residents. Okay, so Braidwood, a recent U.S. District Court ruling, placed limitations on the ability of the federal government to enforce the ACA's requirement that health plans cover a broad range of preventive services without cost sharing. The ACA requires all plans to cover preventive services without cost sharing if the U.S. Preventive Services Task Force recommended them. The ruling determined that any recommendations made after 2010 were not enforceable, which would allow insurers and plan sponsors to remove coverage or charge cost sharing for these services. Examples of preventive services recommended by the task force after 2010 that insurers do not have to cover without cost sharing under the ruling include lung and skin cancer screenings, PrEP for HIV prevention, statins to lower cholesterol, and medications to reduce breast cancer. And we have a full breakdown of preventive services impacted by the ruling in the appendix. Preventive services recommended by entities outside of the task force, such as HRSA and the Advisory Committee on Immunization Practices, are unaffected, and those would continue to be covered without cost sharing. So the ruling will not cause any benefits to change once a plan year has started. However, it is feasible that individuals could see reduced access to preventive services in plan years beginning after the ruling, so as early as 2024. As a reminder for the on-exchange population, to ensure members would not face changes that disrupt their access to preventive services for the 2024 plan year, the Health Connector included language in its 2024 Seal of Approval RFR requiring carriers to continue to cover all of the preventive services required by the ACA and to cover them without cost sharing. MCC offers another tool that can help preserve residents' access to preventive services, including those who do not enroll through the Health Connector. And I can stop here if there are questions so far before turning it over to Andrew. I don't hear anyone. So Andrew, I can hand it off to you.
Thanks so much, Kayla, and good morning, members of the board. So as Kayla mentioned, the Health Connector has a helpful tool in its MCC regulations that it can use to help preserve residents' access to preventive services that the ACA has been providing for over a decade. MCC regulations already require Massachusetts residents to enroll in a health plan that includes coverage of the ACA's preventive health services without subjecting that coverage to a deductible, and that includes the services that are impacted by the Braidwood decision. However, the current regulations permit residents to have coverage that imposes other cost sharing, such as copays and coinsurance, on those preventive services. We are here today to recommend that the Health Connector's MCC regulations be amended to prohibit any cost sharing on preventive services. This is the same standard that has been applicable under the ACA for over a decade and reflects the status quo prior to the Braidwood decision. In other words, this amendment does not add any new requirements beyond those already being offered across the full spectrum of the coverage landscape in Massachusetts. It simply ensconces what is current practice into MCC standards so as to prevent any future diminishment of access for residents. Further, we do recommend an additional clarifying edit to the section regarding the broad range of medical benefits a resident's plan must cover to be those federally defined preventive health services MCC already requires coverage of. This is for the avoidance of doubt and is not a substantive change. And I'll pause here for any questions. Seeing none, I'll move to the next slide. So this slide lays out the timeline for our regulatory process, starting with today's board meeting vote on draft amendments. Assuming that the board does vote to approve these draft amendments, the Health Connector will follow the regulatory process, which includes notice to various stakeholders, a public hearing and comment process, additional edits to the regulations as appropriate based on that process, and then finally an additional board vote on final amendments. Once the board votes to finalize the amendments, they can be published in the next volume of the Massachusetts Register, and that is the date on which the regulations will be effective. Again, I'll pause if there are any questions.
Andrew, Eric has his hand up.
Yeah,
He's
Sure,
still
Eric,
on.
go ahead.
Yeah, it's sort of a technical question, but I think it's important. About 24% of workers in the US are on these plans that are called HSA compatible plans, qualified high deductible health plans. And those plans have deductibles that have to apply to all services except for certain federally defined preventative services. So I just want to make sure, because other states, including Maryland, I believe, inadvertently tripped some rules which put these HSA compatible plans at risk of being non-qualified. So where I'm going with this is I want to make sure that the definition of preventative services follows the federal guidelines, and where we are adding in, as I saw in the notes, some Massachusetts specific definitions of preventive care services, in particular birth control, I noticed. And this is where I believe Maryland almost made a big mistake. So in birth control, my understanding is male sterilization is not considered preventive under the federal HSA qualification rules. And so we want to just make sure two things. One, plans that include some of those services like male sterilization, like vasectomies, we want to make sure if we're including those as preventive in the state, we don't we still allow those plans to be considered. I'm sorry, if plans don't include vasectomies and male sterilization, we want to make sure those would still be considered MCC. And the other thing is carriers, when they're trying to comply with these rules and they cover what the state says should be considered preventative, I want to make sure that the carriers don't inadvertently disqualify their HSA compatible plans. So I know it's a real technical question, and I know we do have some protections in the state regs. I just want to highlight that as an area that other states have tripped on. I want to make sure we don't trip on that as well.
Yeah, thank you so much for raising that point, Eric. And our MCC regulations to treat HSA compatible high deductible health plans as MCC qualifying and give priority to their needs to satisfy any federal requirements to have that status over whatever MCC would require. So I do think we aren't posing a risk to the status of those plans with today's amendments, but certainly to the degree we get questions about how a carrier might design a plan that complies with those federal rules and MCC, it's helpful to have that context, and we'd be happy to support any inquiries we had in that space.
Okay, thank you.
I think Nancy, your hand is up. Thank you, Eric.
Yeah, so I'm just continuing to process what Eric said. So thank you for raising that, Eric. I just wanted to confirm that our carriers are committed, as a number of them have done in public statements, to continue to offer coverage that provides these preventive services with no cost sharing. And that, as we all know, is particularly important in the self-funded market, where employers can make decisions beyond the reach of the state regulation. And that I hope that we have a united community view that preventive services without cost sharing are very important to public health, to individual health, to community health. So I guess my question is, have we heard that kind of support from our carriers?
I'm happy to take that one, Nancy. Thank you for the question. And I would say the answer is yes. We saw very rapidly in Massachusetts the carrier market come out expressing concern about the Braidwood decision and doubling down on their commitment to these kinds of services, and for policy reasons, and I think in the interest of not wanting to see disruption in our market generally. As Kayla and Andrew noted, these are services that consumers in Massachusetts, as well as across the country, have come to count on for the last decade, thanks to the Affordable Care Act. So we were really pleased and appreciative to see how rapidly the Massachusetts carrier market came to the table to say that erosion of these standards is not something that they were interested in seeing. So so I did want to note that, and that's again yet another place where I think we see Massachusetts standing out from the national scene.
Yeah, so I think we should recognize those public stances of the carriers, and just reiterate that being able to continue to have MCC be the kind of, I think, good policy lever it's been in many ways, relies on everyone.
Thank you, Nancy. I think Matt I can't see him, Matt, but I can see his hand.
Yeah,
So
just
Matt, I think you're up. There you go.
Thank you, Mr. Vice Chair. Just to follow along Nancy's comments, the self-insured coverage through the GIC certainly does continue to cover preventive services aligned with the ACA. That's the way we designed our procurement for this year, and we will continue to have our plan design mirror what was in place before the Braidwood decision.
Great. Thank you, Matt. I think the importance of the GIC and how they design their plans is both should be acknowledged and recognized, that it helps have some consistency across the many aspects of the insurance parts of the Massachusetts market. So that's great. If there are no other questions, I think we're going to move to the actual vote. So can we, I think we are a slide down, there it is. All right, so seeing no other questions, Kathy, can we have a vote? I think we might to have the vote.
I'm sure if I could, I think someone has to put the motion forward, probably Michael.
Yeah.
Yeah. I so move.
Seconded.
Okay.
So should we read, I guess, the for the record that the language of the recommendation is that the Health Connector staff recommend that the board issue the draft regulation amendments at 956 CMR 5.00 as proposed. So that's what we're voting on. So Kathy, I think we have a motion in a second. Can we do the roll call?
We sure can. Okay, Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Eric,
Yes.
Martha,
Yes.
Keisha? Knows Keisha? I'll come back. Karen?
Yes.
Nancy?
Yes.
Matt?
Yes.
Rena?
Yes.
And let me come back to Keisha. She's there. Keisha, can you hear me? Okay, she's there, but she's muted.
Well, should we move on? I suppose we should move on. Audrey.
I think that's right. Since you have the votes of everyone else and
Yes.
sufficient for passage.
Yeah, I understand. So the minutes will note that, and I think we're going to move on now. The next item on the agenda, we're going back to Marissa, who's going to talk about policy updates. So Marissa, I'm turning it over to you.
Great, thank you. See if I can advance the slides here. There we go. Okay, so to round out today's meeting, I'll provide brief updates on a variety of state and federal policy developments, just to provide you all with more context for the broader health policy ecosystem that we're working within, including items from federal, judicial, and regulatory activity, as well as state policy activity. So starting with the federal judicial activity, a recent U.S. District Court ruling would revoke the FDA's 23-year-old approval of the drug mifepristone, which is commonly used in medication abortions. This ruling was stayed by the Supreme Court in late April, allowing access to continue unchanged while an appeal makes its way through the Fifth Circuit. On April 10th, Governor Healy issued an executive order reaffirming continued access to mifepristone in the state, under which DOI issued guidance. And we also alerted carriers to the Health Connector's expectation that mifepristone coverage would continue without change. We've also highlighted the Braidwood decision here, which I won't belabor given the presentation that you just heard from Kayla and Andrew, but I would just note that we'll continue to monitor the appeals process in this case, including any limitations on the decision that was already issued that the appeals court could impose. In the federal regulatory space, CMS finalized its annual regulation, the Notice of Benefit and Payment Parameters for 2024 in April. This rule has a variety of updates on different areas of ACA implementation, but I've just highlighted here the ones that most directly impact the Health Connector. Thematically, I'd say these are aimed at reducing administrative burdens to coverage, which we were very pleased about as that aligns with our agency goals. First, the rule changed the process for verifying applicants' income in a couple of ways. It directs marketplaces like ours to accept an applicant's attested income if we try to verify it with the IRS, but the IRS doesn't send us an income in response. This can happen for a variety of reasons, but it's not uncommon. It drives about half of the income verification requests that we send out. And in this scenario today, if someone doesn't return the proof that we've requested, they would lose their subsidies after 90 days. We'll be able to reduce those paperwork requests and the associated eligibility changes under this new rule, which should relieve burdens on individuals. And for those who do still need to send proof of their income, the rule provides an automatic 60-day extension to the 90-day response window that they're afforded. Second, CMS modified the rules for individuals who've received advanced premium tax credits during the year, but then don't file a tax return the following spring to confirm whether the amount that they got in advance based on their expected income is the amount that they really should get based on their actual income for the year. Previously, an individual would have lost their subsidy eligibility for the upcoming year if they had failed to file that return to true up what they'd received. But now this rule would say that someone has to fail to file for 2 consecutive years before they would lose subsidies. And third, CMS removed a prohibition on navigators and assisters using unsolicited means of direct contact to provide enrollment assistance. So we're still working through this change in terms of clarifying for our navigators what is and isn't allowed and how we might want to use the new flexibility in the context of MassHealth redeterminations. But just as an example, we do know that the federal marketplace will be using this rule change to run a pilot program where they would provide navigators in certain areas with a list of eligible individuals in their area who were transferred to healthcare.gov from a Medicaid agency, so that the navigator can outreach and say, hey, it looks like you just lost some coverage, you're transitioning to the marketplace. Do you need help with that? We're here for you. We're in your community. So just an example of how that could be used. And we'll follow up with how our plans might take advantage of these new flexibilities. A second item in the federal regulatory space is a proposed rule that came out late last month that would modify our eligibility rules in the immigration space. So individuals must be lawfully present to enroll with us, and this rule would redefine that term to include recipients of deferred action on childhood arrivals. So this would provide these individuals with access to Health Connector plans and subsidies that they have not been able to access to date. There are also some provisions in the rule that would make similar changes in Medicaid rules around lawful presence definitions, potentially offering individuals some access to MassHealth programs. And in terms of the rule's potential scope here, I was able to find some data that was as late as March 2020 that said there were about 5,500 DACA recipients in Massachusetts. That's likely to have gone down in the last several years, but just to give you a sense for the scope there. CMS has noted they'd like to implement this rule prior to November 1st, so that individuals could sign up for marketplace coverage as early as January 2024 effective dates. And so we're working with Optum and MassHealth to determine what implementation might look like, whether that's feasible, so that we can provide informed feedback in a comment letter back to CMS. And then in the state activity realm, DOI regulations were issued earlier this year, modifying the rate filing process, most notably shifting it ahead in time from July 1st to May 15th, which is coming up fast. When carriers file their rates next week, they'll also submit rate filing summaries to DOI that will be made available online. And DOI will conduct public information sessions also next month. The rules also reflect the end of rating factor flexibilities that CMS had provided for a number of years, but that have now sunset, and it reduces small group rate filings from quarterly to annually. Looking forward, on the horizon is implementation of Chapter 287 of the Acts of 2022, which was from the ballot question last November about dental medical loss ratio requirements. And so DOI has been conducting listening sessions and gathering feedback in preparation to issue regulations to outline how this process will work in the market.
Marissa, can I just ask a question maybe of one of our DOI colleagues? I don't remember what the wording of the ballot initiative was. Do people get a refund or a credit? Does it work the same way as in the ACA?
Yes, it's very similar to the ACA rebates that are available for overpayments of the premiums in that situation. And we are working with stakeholders to try to handle this in the dental arena, which obviously has, kind of different administrative burdens associated with it.
It's long evaded most regulations, so it's a big change.
Thank you. And then finally, in March, the Health Policy Commission held a hearing related to the healthcare cost growth benchmark to hear feedback from stakeholders. And then the commissioners voted last month to set the benchmark at 3.6% for 2024. That's the growth rate as determined by state law. The commissioners have the authority to modify it, but they decided that they were not going to make adjustments for next year. And I'd also just know HPC has been looking at healthcare workforce challenges, and they convened an event with 2 panel discussions in March, looking at workforce issues and how they're impacting care, cost, and equity efforts. So we've been monitoring all of that closely as well. So, we'll continue to follow the litigation and new regulations that are coming out. We're also watching for a federal regulation expected later this year related to short-term limited duration insurance. And we will, of course, be back with updates as things develop in this space, but welcome any questions before we wrap up.
Eric.
Thank you. In the materials, I saw there were a couple contract updates in the email. So just as part of due diligence, had a couple of just basic questions. One was the Worcester site lease extension. It looks like it's month to month. And I just wanted to understand, I assume we pay a premium to do month to month leases. I assume we just aren't in a position to commit to longer. So that was one question on that contract. And then the other one was the policy support consultant. And just as part of due diligence, want to make sure the RL Carey Consulting is a resource we need because we don't have the resources in-house, and that it was at some point subject to evaluation with other providers, and this ended up being the best solution. So those are my 2 just due diligence questions on the contract document.
So, Eric, it's Trish. I can address the Worcester lease for you. We are taking a look at all of our walk-in centers. Potentially, we'd like to co-locate with MassHealth or a different agency rather than paying some of these exorbitant leases and being there by ourselves. Month to month or a 1-year extension actually worked out to be the same increase. So we chose the month to month based on the fact that MassHealth is opening a Worcester site at the DTA location, and I've actually been speaking with EHS folks about potentially co-locating there. So didn't want to tie us into a whole year if we didn't need to.
Thank you.
And Eric, I'm happy to take your second question about the policy consulting services. So I would say, yes, it is the case that we have policy work that right now we just don't have staff capacity to do, largely because of what you just saw the staff walk through, just in terms of how much is moving very quickly that we have kind of heads down on, and have wanted to extend our capability to think more deeply about policy levers that the connector might have, including in concert with GIC, DOI, MassHealth, and others on affordability in kind of an aligned longer term strategy type of way. And RL Carey, for people who may not know, is Bob Carey, who used to be a senior leader at the connector. So folks might be familiar with, who we've done a lot of great policy work with over the years through Gorman Actuarial. And that contract was competitively procured. We put that up to procurement. So it was the winning bid. So happy to discuss more. But I think work coming out of that engagement will be coming forward to this board in ways that you'll find fruitful and forward moving.
Thank you.
Sure.
Thanks, Audrey. Nancy?
Yeah, thank you very much for the policy update. If any board members do read that foundation report on health insurance, and because I'd really encourage all of us to pay attention to and think about the 1 in 5 people who are uninsured, who are undocumented. And I think one of the things the report did really well was just giving us more of a sense of how big a group of people that is, how some of the most profound racial and ethnic disparities are in that group of people, and also what a chilling effect some of the policies of recent years have been on people who are in mixed households. So they themselves may be legally present, but may live with family members or others who are not. And I think as we think about the opportunities that will be presented with DACA folks and others, it's really quite a knotty policy dilemma. There are, I think, some other states who've made more progress on this than we have, but I found those parts of the report to be particularly interesting. And I hope at some point we'll have an opportunity as a group to kind of think more collectively about that because, you know, it's a very large chunk of people who are uninsured, and I think they really need our best thinking and attention too.
Thank you, Nancy. And we can certainly again send that report around. And I would just note your reference to other states that have taken different kind of creative pathways on this front. We have been monitoring some of those policy endeavors. Colorado, New Mexico, Washington State. There's been a number of interesting developments in recent years, including with
California.
and California.
Yeah.
So no, point well taken, and we can find a home for those discussions with this board as well.
Great. Thank you.
Thank you, Nancy. Other questions? All right, seeing none, I'm going to entertain a motion to adjourn. Do I hear a motion?
Motion.
Thank you. A second?
Second.
Thank you, Martha. I'm sorry, Nancy, I saw a hand for a minute, then it went away, Nancy.
Yeah, and I was trying to like raise my hand to do it, but just
Oh, okay.
never mind.
All right, we have a motion and a second, and now we're gonna have a vote, which is always the time I say Kathy.
Hi, okay. Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Eric,
Yes.
Martha,
Yes.
Keisha,
Yes.
Karen,
Yes.
Nancy,
Yes.
Matt,
Yes.
Reno.
Yes.
Thank you, everyone.
Great. So again, thank you to obviously the commissioners are here, and really thank you to the staff. We were so worried about all the stuff that's going on the redetermination. And you guys not only have done an exceptional job there, but the work on minimally credible coverage is really outstanding, given what's been happening. It is just really remarkable, all the stuff that's going on. So with my heartfelt thanks, it's been great to be here, and everybody have a wonderful weekend. So
Thank you, everyone.
bye.
Good night.